On behalf of the International Association of Providers of AIDS Care, or IAPAC, welcome to our Learning Academy. I am Dr. Jose Zuniga, IAPAC's President and Chief Executive Officer. The Learning Academy's mission is to coordinate multidisciplinary online educational activities to support optimal care for people living with and affected by HIV, syndemic conditions, and comorbid diseases. Moreover, we place an emphasis on innovative interventions to address challenges faced by people who are vulnerable to HIV, viral hepatitis, tuberculosis, and non-communicable diseases. This educational activity is focused on culturally responsive care to optimize HIV outcomes. Its aim is to provide an overview of strategies to address the implicit role that culturally specific barriers play in limiting universal access to and utilization of HIV services by key populations. The activity's first module defines culturally specific barriers in relation to accessing and utilizing HIV services, including culturally related patient preferences and values, patient literacy, language, and affordability. The second module identifies approaches to integrate culturally responsive standards into clinical practice to eliminate age, gender identity, and racial as well as ethnic biases. Finally, the last module defines strategies to operationalize continuous quality improvement plans to address gaps in culturally responsive care delivery in clinical practice.
Hello, and welcome to Culturally Responsive Care to Optimize HIV Outcomes. I'm Dr. Sheldon Fields, your moderator and presenter for this webinar today. I am an HIV/AIDS research scientist and someone who has been involved in the care of HIV patients as a nurse and a nurse practitioner for over 30 years. So it is with that perspective that I will be presenting some of the information that I have to share with you today. I'm really glad that you have joined us and you want to learn more about how we can truly, from a culturally responsive way, optimize what we need to do in order to work with our clients as we endeavor to end the epidemic. So, as I said, I'm Dr. Sheldon Fields, and in my other role, I'm the Associate Dean for Equity and Inclusion at the Penn State Ross and Carol Neese College of Nursing. And today's webinar is being presented to you from an educational grant from Janssen Therapeutics and Merck. There are three overarching learning objectives for this webinar today. We're going to talk about and help you to understand the implicit role that culturally specific barriers play in limiting universal access to and utilization of HIV services by key populations. We're going to talk about how to identify approaches to integrate culturally responsive standards into clinical practice to eliminate age, gender, identity, and racial ethnic biases. We're also going to talk about how do we define strategies to operationalize continuous quality improvement plans to address gaps in culturally responsive care delivery in clinical practice. So before we really can understand what the implicit roles that culturally specific barriers play in limiting universal access to and utilization of HIV services by key populations, we need to explore some terminology. So we're going to do that by starting with how do we define some key terms. So when we talk about key populations, we are referring to those groups who, due to their specific higher risk behaviors, are at an increased risk of HIV. When we talk about culturally specific barriers, what we're talking about are cultural factors such as eye contact or hygiene that affect access to care. When we're talking about universal access, we're talking about everyone having access to timely use of healthcare services in order to achieve their best healthcare outcomes. Key populations. So key populations include people at risk for HIV based on things such as gender identity, sexual orientation, and other sociodemographic factors. As we think about our key populations, we will learn more about these key populations in more depth as we go through. Listed here are some of the key populations in which we are going to specifically address today. So men who have sex with men, transgender individuals, sex workers, people who inject drugs, people in prison, or other settings. So according to UNAIDS, we understand that certain groups are at a higher risk of HIV acquisition than the general population. So as you can see here on this slide, female sex workers are 26 times at greater risk. People who inject drugs at 35 times. Gay men and other men who have sex with men at 25 times. And transgender women at 24 times greater risk than the general population. So to help us better understand our population of focus, I want to welcome you all to Ending the Epidemic USA, or better referred to as ETE. This is a mixed community with all the opportunities, much like any large city you would find in the United States. As we move through the rest of this presentation, we will walk through various situations and meet ETE patients that will help us to think through the learning objectives that we presented earlier. Our first slide will start the story, but watch how our center transitions throughout the rest of the presentation. Before we meet our patients, let's talk about the key populations for just one more minute. So specifically talking about men who had sex with men. And you'll see on a slide here, the CDC reports minority populations that make up the majority of new diagnoses among men who have sex with men, or MSM. So we're going to introduce you to Jose, who is a Hispanic MSM living with HIV. We will hear more from Jose later on, but you can see in this slide that the proportion of men who have sex with men at risk for HIV is higher amongst people, those who identify as people of color compared to their white counterparts. When it comes to minority, transgender individuals, you will also see that certain individuals bear a greater burden of new HIV diagnosis. And we're going to introduce you to Flora's story pretty soon. But most new HIV diagnoses amongst transgender individuals were among Black or African American people. When it comes to sex workers, there is an overall lack of data. Although the CDC still does highlight that they are indeed at an increased risk of HIV acquisition, noting primarily socioeconomic, sexual risk factors, drug and alcohol use that's often involved, and knowledge of HIV status as a risk factor. When we're talking about people who inject drugs, the new diagnoses among people who inject drugs in the United States, the risk factors in the CDC reports that it has remained somewhat stable, with some areas having recent prevention challenges placing new populations at risk. And for this, you're going to hear about Katie, who is also seen within our ETE. Prisoners. UNAIDS estimates that people in prison are 5 times more likely to be living with HIV compared with adults who are not incarcerated. The World Health Organization estimates the difference to be even starker, suggesting prisoners are 15 times more likely to be HIV positive than those who are not in prison. And for this, we're going to introduce you to Luther, who contracted HIV while in prison. So now that we've identified our populations, let's dive into the barriers that they may be faced with. Use or non-use of healthcare services may be attributed to things such as culturally related patient responses and values, patient literacy, lack of information, or a lack of understanding of the actual clinical situation. Other barriers that have also come up are things such as general affordability, language, and transportation. Now, let's meet some of the other ETE health center patients. So now, let's meet Jose. Jose has lived in the ETE for a little over a year. When he came to America, he had a hard time getting on his feet. He slept on a friend's sofa and had casual sex as payment. Jose contracted HIV through MSM contact from that friend. Jose speaks very little English, so he has had a hard time communicating with his healthcare professionals. Oftentimes, they don't have anyone who can translate, so his visits are often short and don't cover all of his issues. Jose once mixed up taking one of his prescriptions, thinking that once on the bottle was actually once or 11 in Spanish. Fearing deportation, Jose knew that the only option was to go to the ER. However, the ER thought that he had actually tried to commit suicide until the translator in the ER explained everything. While Jose is resting well, he still doesn't know the status of his living situation. Just think of the countless others that are experiencing some of the same issues. So now, let's meet Flora. Flora is a longtime resident of ETE. Raised on the East Side, Flora has lived and seen it all. As a youth, Flora was sexually abused, and at the time, his foster father for years. So as an adult, she used sex as a coping mechanism and thus contracted HIV. Flora hates going to the ETE healthcare system, but it's the only place that she can go since she has no income and is close to her house. The staff there just don't understand her. They call her by her government name, which is Larry, and uses the wrong pronouns. She wasn't happy with the fact that she could only see the NP and not the actual doctor. Over her HIV journey, she has always seen the doctor, and usually a female doctor, in which she felt more comfortable sharing her challenges and her needs. Now I want to introduce you to Summer. Most people think that culturally barriers only occur among those of the minority populations. Our next two ladies will have very compelling stories to help you understand that cultural barriers can exist for anyone given their circumstances. So meet Summer. Summer was raised in a well-to-do family, attending the best schools. Summer started modeling during school. The pressure of everything led to her drug use. In order to avoid asking her parents for money and not raise suspicion, she decided she would start having sex with guys on campus to feed her habit. Eventually, she ended up acquiring HIV. Summer was ashamed and stopped communicating with her family. She went to the ETE health center to avoid the stigma of going to the center that her parents went to. Summer was not used to being treated in the way that quote-unquote normal people were subjected to care. She felt as though she was looked down on and judged for her choices that she had made. Next, let's meet Katie. We generally find that young white women like Katie are living with HIV due to IV drug use. So let's meet Katie. Her mom overdosed and she went to live with her grandmother who was on disability at the time, making things financially difficult at the home. After school and during summer, she would hang with her friends. And then in order to make some extra money, she started having sex with them. Katie has expressed that she feels as though her female nurse practitioner seemed a little bit aloof and not really interested in hearing her needs, but rather moving her along in the office visit. According to the client, she felt as the provider was operating in just a routine manner and didn't demonstrate any empathy or perhaps a deeper understanding of her current situation, especially being that she uses IV drugs to cope. And last but certainly not least, I want you to meet Luther. Luther contracted HIV while in prison. Since his release, he is now seen at the ETE healthcare system for medical services along with everyone else. He recently concluded that his provider was not interested in knowing me as a client and oftentimes had outdated information on him about his labs or other tests that they should have reviewed in his files. The PCP asked if he had a recent syphilis screen. Curiously, I wondered if they were adequately monitoring his care. Wouldn't they have ordered that with his labs or perhaps inquired as to my sexual history? The PCP, during their brief session, asked the client, "How is your mother?" who was also a patient at the ETE. The patient replied, "I reported her death to your office months ago. It was an awkward moment that let me know that maybe I should find someone else because he obviously wasn't listening." As you can see, key populations experience both increased impact from one or more of the diseases and decreased access to services, widespread stigma and discrimination, state and non-state violence and harassment, restrictive laws and policies, and criminalization of behaviors or practices, put to key populations that are at heightened risk and undermine their access to services. So now we're going to switch gears a little bit and talk about how to integrate culturally responsive standards into clinical practice. And by identifying these practices, we'll have a better understanding of how to better serve these people in the key populations that we've discussed. Before we start, let's look at some key terms. The American Medical Association, or the AMA, defines culture as a learned pattern of knowledge, beliefs, behaviors, and norms shared by members of a racial, ethnic, religious, or social group that is passed down from one generation to the next. These groups could be some of the ones we've defined earlier, such as prisoners, LGBT, Hispanic, Latino, Black, etc. The AMA defines culturally responsible care as medically competent care that is adopted to meet cultural specific needs of individualized patients. From this statement, we see that care is supposed to be individualized to the patient. We can ask ourselves, do we sometimes get so busy that we find ourselves just going through the routine? Do we actually take the time to really get to know our patients? At the physician level, the U.S. Department of Health and Human Services defines culturally competency as the level of knowledge-based skills required to provide effective clinical care to patients from a particular ethnic or racial group. In further defining key terms, we can see in this section, we have a lot to unpack. So how do we achieve culturally responsive care? First, we have to recognize their own cultural beliefs and potential biases. Then we have to be more aware of the relationship of cultural customs and beliefs to health behaviors. And lastly, understand disease prevalence, incidence, and treatment outcomes for different patient populations. The national standards for culturally and linguistic appropriate services, or CLAS, in health and healthcare are intended to advance health equity, improve quality, and help eliminate healthcare disparities. As we walk through these standards, we will think about our patients at the ETE Health Center. The principal standard of the National CLAS Standards is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. What do you notice about our site in this particular slide? You notice that there are a lot of factors that come into play in trying to build equitable and culturally responsive services. The next set of standards cover governance, leadership, and workforce standards. We have to advance and sustain organizational governance and leadership that promotes class and health equity through policy, practices, and allocated resources. We have to recruit, promote, and support culturally and linguistically diverse governance, leadership, and workforces that are responsive to the populations in the service areas. We have to educate and train governance, leadership, and workforce in culturally and linguistically appropriate policies and practices on an ongoing basis. Do you notice a difference in the ETE Health Center staff? Communication and language. If we're looking at standards 5 through 8 that really focus on communication and language assistance, these standards that we have to offer language assistance to individuals who have limited English proficiency and or communication needs at no cost to them in order to facilitate timely access to all healthcare services. Number 6, inform all individuals of the availability of language assistance services, clearly and in their preferred language, verbally and in writing. We need to ensure, with number 7, the competence of individuals providing language assistance, recognizing that the use of untrained individuals and or minors as interpreters should absolutely be avoided. We also need to provide easy to understand and multiple materials and signage in the languages commonly used by the populations in the service area. When it comes to standards 9 through 11, they focus on engagement, continuous improvement, and accountability. Standard 9 talks about establishing culturally and linguistically appropriate goals, policies, and management that is accountable, and infuse them throughout the organization's planning and operations. Standard 10 talks about how do we conduct ongoing assessments of the organization's class-related activities and integrate class-related measures into measurement and continuous quality improvement activities. Standard 11 talks about how to collect and maintain accurate and reliable demographic data to monitor and evaluate the impact of class on health equity and outcomes, and to inform service delivery. So as we continue to look at engagement, continuous improvement, and accountability standards, we have to be mindful. In order to do any of this, we need to conduct regular assessments of community health assets and needs and use the results to plan and implement services that respond to the cultural and linguistic diversity of populations in the service area. We need to partner with the community in order to design, implement, and evaluate policies, practices, and services to ensure cultural and linguistic appropriateness. We need to be able to create conflict and grievance resolution processes that are, again, culturally and linguistically appropriate in order to identify, prevent, and resolve conflicts or complaints. We need to be able to communicate the organization's progress in implementing and sustaining class to all stakeholders, constituents, and the general public. It is all about accountability. Now, we have all the tools to provide universal access to care for our ETE clients as defined by the World Health Organization, meaning universal health coverage for all people, patients having access to the health services they need, when and where they need them, without financial hardship. It includes the full range of essential health services, from health promotion to prevention, treatment, rehabilitation, as well as palliative care. Health for all, and health systems that protect everyone regardless of race, religion, gender, or wealth, is not only a human right and a prerequisite to achieving sustainable socioeconomic development. Our journey keeps us on a road to primary healthcare-based systems that are effective in empowering communities to choose healthier lifestyles, prevent diseases, and access early detection, treatment, and recovery services. So now we've done all the hard work in reaching cultural competency and culturally responsive care. Let's strategize on continuous quality improvement. Let's start by defining continuous quality improvement. The Minnesota Department of Health defines continuous quality improvement, or CQI, as a deliberate and defined process which is focused on activities that are responsive to community needs and improving population health. It is a continuous and ongoing effort to achieve measurable improvements in the efficiency, effectiveness, performance, accountability, outcomes, and other indicators of quality for state and local program levels. In this section of the webinar, we will examine the use of Plan, Do, Study, Act, or what we refer to as PDSA, learning cycles and continuous quality improvement in healthcare, and review two strategies to address gaps in culturally responsive care delivery. The National HIV-Qual Project and a protocol for improving cultural competence in a context of substance use disorders. But first, let's begin by defining some terms. Again, quality can be defined by how well we meet the needs of those we serve. Most problems are in process, not people. Unintended variation in processes can lead to unwanted variation in outcomes. Continual improvement can be achieved through serial experimentation. So here you have a model of CQI, and you can see that it responds to what is currently going on, the people, process, and technologies, the meaningful use of such, in order to go from the current state to the future state, which is hopefully improved patient care, improved population health, and reduced cost. CQI improvement in healthcare seeks to examine the current state. In this case, culturally responsive care delivery and how to use people, processes, and technology, such as the electronic medical records, SMS, to achieve a future state of improved patient care and outcomes, improved population health, and again, cost effectiveness. When it comes to modeling for developing cultural competence, we have to look at this in terms of dimensions. Dimension 1 includes the main population groups as defined by the U.S. Census Bureau. So African and Black Americans, Asian Americans, Hispanic and Latinos, Native Americans, White Americans. Other multiracial and culturally diverse groups, such as sexual orientation, gender orientation, socioeconomic status, and geographic location, can also be added to the model. Dimension 2 includes the core elements of cultural competence. Now, this dimension includes things such as cultural awareness, cultural knowledge, and culturally appropriate clinical skills. To provide culturally responsive treatment services, providers and organizations need to become aware of their own attitudes, beliefs, biases, and assumptions about others. Providers need to invest in gaining cultural knowledge of the populations they serve, and they need to obtain specific cultural knowledge as it relates to help seeking, treatment, and recovery. This dimension also involves competence in clinical skills that ensure delivery of culturally appropriate treatment interventions. Dimension 3 focuses on culturally responsive services. This dimension targets key levels of treatment services: the individual staff member level, the clinical and programmatic level, and the organizational and administrative level. One strategy that is commonly used in healthcare settings is to operationalize CQI in the PDSA cycle. The PDSA cycle is an iterative design and management method used in continuous improvement of processes and products. It is commonly employed in CQI improvement in healthcare settings. It is also known as the PDCA cycle. Remember that: plan, do, check, act, or plan, do, check, adjust. The planning phase establishes the objectives and the processes required to deliver the desired results. In the do phase, the objectives and the processes from the planning phase are then implemented. During the study phase, the data and results gathered from the do phase are evaluated. Data are then compared to the expected outcomes to see if there's any similarities and or differences. The testing process is also evaluated to see if there were any changes from the original test created during the planning phase. The act phase is where a process is improved. Records from the do and study phases help to identify issues with the process. These issues may include problems, nonconformities, opportunities for improvement, inefficiencies, and other issues that result in outcomes that are evidently less than optimal. Root causes of such issues are then investigated, found, and eliminated by modifying the process. Risk is then reevaluated. Planning for the next cycle can proceed then with a better baseline understanding. Theories and ideas that turned into changes that result in improvement through repeated small experiments in change using multiple PDSA cycles. So we're talking about a process that is dynamic, not static. So the use of PDSA cycles to conduct small-scale tests of change in real settings in order to plan a change, do it in a small test model, study its effects, act on what is learned. The team then can use the links in the small PDSA cycles until the changes are ready for broader implementation. And that's about how do we actually use the PDSA cycles. Now, when it comes to PDSA cycles that are actually in action, this is about being able to apply culturally responsive care delivery in clinical practice. PDSA cycles are a continuous process with knowledge and process changes learned from the previous cycle can then be applied to the next cycle. Continuous quality improvement process in terms of the PDSA cycles from part of the continuous process of quality improvement in health alongside of root cause analysis, intervention, impact evaluation, and sustainability. The continuous process then has 5 phases. 1, project phase. 2, the diagnostic phase. 3, the intervention phase. 4, the impact phase. And 5, sustaining improvement phase. Again, dynamic, not static. So let's talk about the National HIV-Qual project. And this will help us review strategies for quality improvement in health. So the National HIV-Qual project from the New York State Department of Health and Health Resources and Services Administration, improving cultural competence from the Substance Abuse and Mental Health Services Administration within the U.S. Department of Health and Human Services. So the HIV-Qual project represents the joint efforts of the New York State Department of Health AIDS Institute and the Health Resources and Services Administration HIV/AIDS Bureau, or what is commonly referred to as HRSA. Key HIV-Qual project goals and objectives are to improve the quality of care for persons with HIV receiving care, promote quality improvement activities, promote self-reporting of HIV performance, measurement data based on clinical guidelines, provide site-specific consultation to build quality improvement capacity, which is responsive to the specific organizational needs of various grantees. So what is HIV-Qual? And what does the program actually consist of? Well, there are 3 key elements: quality improvement, performance measurement, infrastructure, and capacity. So HIV-Qual is a model for building capacity for quality improvement that is designed to improve care for people living with HIV. And it consists of the 3 key elements that I just discussed. What are the HIV-Qual methods? The HIV-Qual model uses the following methods: coaching, on-site mentoring of a national team based at the Ministry of Health that emphasizes structure, planning, and QI projects, supplemented by training workshops. Performance measurement, which is facility-level data which are collected and used to improve care and participate in clinics. Data are then aggregated to produce regional and national benchmarking reports. Implementation. The QI projects focus on improvement of selected aspects of ambulatory care through process investigation and small tests of change. Peer learning. Regional groups are created for providers and facilities to share experiences and facilitate coordination of quality improvement work. Local government sponsorship of the regional groups also occurs. The National HIV project cycles. So to achieve sustainable improvements in quality, the HIV model focuses on both the structural programmatic level and on the project level. The program cycle consists of 3 steps, and the project cycle consists of 6 steps. The HIV-QoL workbook is based and structured on the HIV-QoL model and its program and project cycles. Workbook context explains the purpose of each cycle and then describes the key tasks for its successful completion. The program cycle then focuses on the necessary steps to plan, build, and sustain an HIV-specific quality infrastructure, while the project cycle shows how to actually implement a quality initiative to improve one aspect of HIV care. The HIV-QoL workbook provides you with a practical guide for improving the quality of HIV care, offering a step-by-step guidance on how to build a quality program, orchestrate quality improvements, and then sustain those improvements. So let's move now to improving cultural competence protocol from the Substance Abuse and Mental Health Services Administration, or SAMHSA. The treatment protocols, or TIPs, were developed by SAMHSA and HHS. TIPs are best practice guidelines for the treatment of substance use disorders. TIP series fulfills SAMHSA's mission to reduce the impact of substance abuse and mental illness on America's communities by providing evidence-based and best practice guidelines to clinicians, program administrators, and other payers. Tip 59, improving cultural competence. So tip 59 specifically addresses cultural competence on how to improve it at an individual and organizational level, using the principles of continuous quality improvement and the PDSA cycles, mentoring, training, workforce and staff development. The development of culturally responsive clinical services is vital to the effectiveness of behavioral health services. Cultural competence is a dynamic, ongoing developmental process that requires a long-term commitment and is only achieved over time. Culturally responsive skills can improve client engagement in services, therapeutic relationships between clients and providers, and improve treatment retention and ultimate outcomes. Cultural competence is an essential ingredient in decreasing disparities in behavioral health. The quick guide provides succinct, easily accessible information to administrators about developing culturally competent organizations. The guide is based entirely on improving cultural competence. Number 59 in the Treatment Improvement Protocol Tip Series. Achieving cultural competence. So, becoming culturally competent is a developmental process that begins with awareness and commitment and evolves into skill building and culturally responsive behavior within organizations and amongst various providers. Culturally responsive services provide a greater sense of safety from the client's perspective, offer clients a chance to explore the impact of culture, including historical and generational events, acculturalism, discrimination, and biases, and allows clients to examine how these things impact and relate or affect their mental and physical health. They recognize the fundamental importance of language and the right to language accessibility, including translation and interpreter services. It honors the belief that culture is embedded in clients' language, implicit and explicit communication styles. It acknowledges that language accommodating services can have a positive effect on clients' responses to treatment and subsequent engagement in recovery services. Culturally responsive treatment can only occur when the making of clinical and programmatic decisions includes culturally relevant information and practices and is endorsed and supported by clinical staff, clinical supervisors, and the organization as a whole. In addition to provider cultural competence, it is critical to have organizational cultural competence as well. Beginning with the organization's vision and mission statement, administrators and governing boards need to develop, implement, and support a strategic planning process that demonstrates commitment to cultural competence. Key staff members assigned to oversee the development of culturally responsive services act as liaisons and facilitators in establishing a cultural competence committee and conducting an organizational self-assessment of cultural competence. With the improvement and involvement of community members, staff, clients and their families, board members, and other invested individuals, the Cultural Competence Committee is then able to support and oversee organizational self-assessment, using it to identify strengths and specific areas for improvement in cultural responsiveness. Based on the results of the self-assessment, the committee can then move to develop and implement a cultural competency plan. So there are 9 steps in planning for organizational cultural competence. Step 1 has to do with engaging clients. Step 2 has to do with familiarizing those clients and family members with the evaluation and treatment processes. Step 3, endorse a collaborative approach in facilitating interviews, conducting assessments, and planning treatment. Step 4, obtain and integrate culturally relevant information and themes. Step 5, gather culturally relevant collateral information. Step 6, selecting culturally appropriate screening and assessment tools. Step 7, determining readiness and motivation for change. Step 8, providing culturally responsive case management. And step 9, integrating cultural factors into the actual treatment planning. In summary, PDSA learning cycles are an important strategy in continuous quality improvement. Keys to culturally responsive care delivery and quality improvement, performance measurement, and infrastructure and capacity building. The focus of culturally competence and practice has historically been on individuals. However, providers will not be able to sustain culturally responsive treatment without the organization's overall commitment to support and allocate resources that promote these practices. Ultimately, we're talking about sustainability of these culturally responsive treatments. We need to work to make this your health center. We need to create a patient advisory board with representation from key populations. We need to listen to understand, then respond. We need to set goals to review quality improvement plans and be ready to act on barriers and address them directly. So what tools can we help add to your quality improvement plan is a very valid question that we should be asking. Culturally specific barriers, culturally responsive standards in clinical practice, continuous quality improvement, in order to achieve cultural competence are all the things that we were able to discuss and review throughout this webinar, giving you some best practices and exemplars of how to achieve these particular outcomes. As we come to the end of the webinar, really want to thank you all today for your time, your patience, and your full consideration for everything that we've discussed today related to cultural competency, as we really do want to strive to have better outcomes for our patients. Again, I am Dr. Sheldon Fields. Thank you for your time.
Thank you for participating in this IAPAC Learning Academy educational activity. I appreciate your commitment to delivering quality, person-centered, culturally responsive HIV care that leaves no one behind. Now, more than ever, we must focus our efforts on regaining momentum to avert AIDS-related deaths, stem new HIV infections, and eliminate HIV-related stigma. As a clinician, you are critical to those efforts.